Hi there. Today I'm here again with my friend and colleague Rani Anjum from Norway. And Rani works in the CauseHealth project. And we've spoken to her earlier in this unit of study. And today I'm going to ask Rani to talk a little bit about evidence-based medicine. Hi, Rani. It's lovely to see you.
Hi. Thanks for having me.
Hey. So this week in our unit of study, we're looking at evidence-based medicine and the different ways that it's understood and some criticisms that have been made of it. So, for example, we've had it characterized as an ideology of care, so an approach that sort of directs us as to how we ought to practice medicine, and also as something like a value system that privileges a certain kind of knowledge, either in healthcare or about healthcare. So I wonder if you could say a little bit about whether you would agree with either of those characterizations and how you would understand evidence-based medicine.
Well, I think it's interesting to call it a kind of ideology of care and to say that there are these values, because I think that it's a very strong value in evidence-based medicine that everyone has an equal right to the best care. And it seems like this equality principle is really prominent because it's not so much about getting a treatment that is adapted to you. It's more about getting standardized care that everyone should at least get this, and this, so that you maybe follow a kind of checklist, or you look at the available information and you review it. But what is best to do is basically generated by evidence that is collected elsewhere, not from this particular patient, but from other patients. And one thing that I think is really implicit in that kind of thinking is this kind of rule utilitarian approach, where you apply the rule that in general benefits the most. So if you see in a study, for instance, that most people got better from this type of treatment, then you follow that rule in general, and then in average, most people will be better. So it means that it is a very much a population level value system for care, I would say, where you think from a public health perspective, and not so much maybe from the clinical perspective, because then you would have to open more for the contextual considerations, which I think we have also talked about this earlier, because the individual clinician and the doctor used to have a lot of autonomy to make decisions, and then different doctors would make different decisions, and maybe different patients could afford different quality of healthcare. So someone got better treatment, someone got the treatment that their doctor really liked. So it's like, okay, stop with that. Now everyone should get the best. But of course, if we knew what was best, and if we knew what was best for everyone, I would agree. But if the best is the best in average for the studied population, that is not maybe representative for the patients that normally come seeking care, then I would say it's a bit of a tension there between, okay, the context of where the evidence is gathered and the context where it's applied.
So I wonder if that, like, it sounds to me, I mean, the statement that healthcare should be based in good evidence seems extremely non-controversial. Everyone would agree with that. But it seems that you maybe have some issues with what counts as evidence. Like, what is the evidence which is relevant to deciding what is the best treatment for this particular patient?
Yeah, very much so, because the notion of evidence has been redefined completely in later years in medicine. So evidence now should mean evidence from randomized control trials. And that's the most important type of evidence that you could get, and meta studies from randomized control trials. But evidence could also mean kind of mechanistic knowledge about how things interact, how things work, which is not something you can study just by giving people a treatment and seeing whether or not they get better. So if evidence is like very closely related to correlation data and comparison of correlation data. So for instance, you see the correlation when people get the treatment, and you compare it to the correlations where people get a placebo or another treatment, and then you analyze and hopefully more people in the group that got the treatment that you tested got better than in the other group. But if you want to think of causal evidence as something that also explains to you what is actually going on and what is working for the different types of individuals, then you need to have more theoretical and mechanistic knowledge. And of course, there's also evidence coming from the patient. So the patient will have a lot of evidence about, so for instance, just think of how genetics is interacting. So for instance, in order for a treatment to work, it has to interact with your body. And if you have it, of course, everyone has a unique genetic setup. So if you don't have the genetic setup to interact, you wouldn't be what we call an appropriate partner for that treatment, and it wouldn't work for you, but you might still get side effects. So it's like, okay, so what is best for you? It has to be informed by evidence also from you and knowledge about how that treatment works in you. So but I know that the patient evidence is seen as something that if it comes from the clinic, it's anecdote. But if it comes from a clinical study, it's evidence. So if you're part of a study, then it matters what happens to you. But if you're not part of a study, then you're just a story.
Yes. But then, so you touched on something then with genetics, right? So everyone has a unique genetic composition, and this is particularly the case, or in many more and more aspects of healthcare now are influenced by genetics. But if we look at something like cancer treatment, there are lots of different sort of genetic variations which can give some insight into how patients will respond to treatments, and also mapping the genome of a tumor can also make that even more granular distinctions about what might be the most appropriate treatment. So would you say that kind of what you would call personalized medicine, is that still does that still fit within the evidence-based medicine paradigm, would you say?
I think any kind of treatment where you need to adapt to the individual is going to be complicated from a public health perspective. So I think very often when people hear that we want to have adapted treatment, they would assume that it means personalized. But personalized very often means purely genetical. It doesn't mean, for instance, that it's something about your context. I mean, whether you're in a wheelchair, so you cannot exercise. So if you go to the physiotherapist and they say you need to do the knee bend or whatever, and there's no way you can do it. So, or if you get side effects from painkillers and you can't take them, so you need to do something else to manage the pain. So it's not so that level. That's part of the kind of adaptive treatment that I would say is really important. But I think the general idea in evidence-based medicine, as you say, everyone should get the best possible care based on the best available evidence. That in itself is completely empty, and everyone would agree. So unless we actually unpack what does it mean that you have the best evidence, the best available evidence, and the best care, what counts as these things, that's going to be entirely dependent on the system. And evidence-based medicine, they have very specific ideas, because when they talk about evidence, they talk about the things that you can observe directly, because it's extremely empiricist. So theory is thought of as quite suspect if it's not backed up by data. So you can have an idea that this is going to work for you, but if you have no data to show, it's like, what do you know? So in Norway, for instance, it took so long before they even recommended masks, and I'm not sure if they still recommend people using masks in the corona situation. And the reason for that is that they had this population-based type of evidence where they were looking for RCTs. So there are no RCTs.
Oh,
No
yeah.
statistical studies showing that it works. So they didn't care
Yeah.
about so much the mechanism. And then they also had to factor in things like, well, what if you use it wrong? If you don't use it in the right way, then, well, the outcome is not going to work. And if you cannot see that that you are reducing how many people get ill, then yeah, so the data is always the prominent type of evidence. But then, of course, any kind of precautionary principle or mechanistic type of argument is not going to count.
Right. That's I think a really important problem with the evidence-based medicine approach, that there are so many questions in healthcare that you can't design an RCT to answer that question.
Oh, other things with the RCTs is that you cannot have complex illness when you participate, because you only check one treatment at a time. And if you have a chronic complex illness, then you're very likely to be excluded from any kind of clinical trial, because they need to have a certain type of patient. And some people we worked in the CauseHealth project, clinicians, they said, well, none of their patients were ever part of clinical trials. So why assume that the patients who are part of the clinical trial are representative for the individuals that you see every day? And we know that, for instance, to have more than one problem, so comorbidity, multimorbidity, that is the norm. It's not the exception. But if they're not part of any trial, then, and if you have like a high risk of side effects, for instance, that might also be a reason to take you out of a trial, which means that the people in the trial have very small chance of side effects or severe side effects. So the results are going to seem much more positive. You see, so if you say that, well, this is safe and effective, but you have taken out people where it maybe wouldn't be safe or effective. That's something that we need to factor in the communication of these results, but it's not. And then in addition, if you do meta studies of RCTs, then of course the published RCTs are going to be the ones that show the positive outcome, because if it's negative results, they maybe wouldn't be published. So
there are a lot of issues. So given all those sort of issues with that approach, what role do you think that evidence-based medicine should play in clinical care?
So I think evidence-based medicine, a lot of people have said that you need to swap the evidence-based with evidence-informed. So clinical decisions should be informed by evidence, but also the notion of evidence has to be much, much more than RCTs and meta studies of RCTs. So you should value different types of evidence, because it's not everything where you can do an RCT. So there's a lot of type of treatments where also you would definitely know whether you're in the treatment or in the placebo group. So this is a type of format that is made for pills, so pharmaceutical interventions. So I think the informed by evidence and multiple types of evidence, that's the direction that it's going in, the criticism of EBM. And I think maybe that is more in line with what the general idea, the general intention was anyway. But it came also with the hierarchy that was very much informed by the empiricist approach, and I would say certain understanding of probability, that you look at how often something happens in the population, and that would tell you what's the risk or the probability that it's going to work for benefit or harm you. So I think the challenge with EBM is that it's very general idea, general guidelines, it's standardized, but then in the clinic, everyone's different. Why would you assume that you could do the same with lots of different people and get the same type of outcome? So that would be the criticism.
It's privileging that very rigid hierarchy of the different kinds of evidence when so if we can think of evidence as something more broad, which includes the patient's story and the whole context of their life, as well as our understanding of physiology and the causal processes that might be working, and all those different things, they're all relevant evidence for the particular patient.
Yeah, because you could say people are sufficiently the same to say something general. But you could also say that, well, from a biological perspective, we are also quite different in certain ways. So there are some relevant differences that needs to be accommodated, but that will be evidence from that patient. And also that stage of the patient's illness or recovery is going to be relevant.
Yeah. Great.
Yeah.
Well, that's fantastic. Thank you, Rani. It's been lovely to chat with you.
I hope it was useful.
Yes, definitely. It's great to hear your perspective. Thank you so much.
Thank you.
Thanks.